Could you kind of give us an idea of a little bit insight of the unit where you're working and what that looks like?
Yeah, so we work. Well, I work for the Manchester Foundation Trust. So the Manchester Foundation Trust is a it's one of the biggest hospital trusts in the UK, and it incorporates. Actually, we're very fortunate. We incorporate um, adults, children, neonates, as well as ophthalmology, actually all under one roof. Um, so for me, working at the Manchester Foundation Trust, it's a you know absolute joy to be able to walk down the corridor from my eye clinic and into St Mary's and into the neonatal unit any time of day, really. Or, not necessarily on demand, but if required, I could go there at any time. And I've worked closely with the many of the clinicians that work at St Mary's with the neonates, the neonatologists, the neonatal nurses. I've got a group of absolutely magnificent neonatal nurses who are involved in ROP, and as you know, Vic, they are involved in actual screening for ROP using the retinal cameras. Um, I've been working there now for 22 years
Uh,
at St Mary's, and we've been using nurse-delivered retinal screening for probably more than 15 years or so. And we started off initially with, a small mobile device from another company, but since then, more companies have been around. We've trialed different devices. What we liked about the Icon was the quality of the image, and I think ultimately what I felt was the nursing team were the ones who were taking the images. They needed to be comfortable with an item of equipment that they felt was comfortable in their hands, that they could use
mhm.
in these neonates, and that they felt they could deliver consistently good images from. So, to a large extent, I left it up to them to decide which was the best device. So, given that that was the case, they have gone with having trialed different models. They have gone with the Icon, um, and um, uh, and what's now uh, happened with that, which is something that I've always wanted right from the start, was a seamless flow of being able to have an organized list of patients who require screening, being able to uh, request images on those patients, and then having those images available and archived long term for the NHS. I mean, these are babies who, you know, they're going to have long lives ahead of them, hopefully, and
Mhm.
we need to be able to access these images for more than 20 years down the line. So from a record keeping perspective, from a legal perspective, having something that's archived on an NHS system which is secure. Um, we use the PACS the PACS system, and that's now been set up so that we are able to um, store these images on packs, and we can view them now at our workstations, and we don't even have to be on the unit to do that. So that's amazing. So if I get a message through our electronic messaging systems that, oh, can you have a look at this baby? The images that we've just taken, I can then just go on and have a look at through our electronic patient record, access packs, have a look at the images, send an immediate message back, and that patient's management is done very smoothly um,
Mhm.
from wherever I am in the hospital. So this is a dream come true, really, as far as I'm concerned. This is how RAP screening should be done. It should be delivered by people with a technical expertise to be able to consistently get good quality images.
Mhm.
We should be there, being able to, as a clinician, review those images, ensure that the quality is good enough, be able to grade those, and be able to make a decision that doesn't depend on me being available to walk onto the unit there and then, and then that patient is very swiftly and efficiently managed through their episode. So yeah, so we've achieved that, which is an amazing thing.
Yeah, well, that's great, and I think thank you for kind of sharing that. And I think a couple of the points that you mentioned there. First is to have a team of ROP screening nurses, and we've had the opportunity to hear from Julie Flanagan, who's one of the senior nurses there, and I know that she's been kind of pioneering in the project and the training rollout of helping other nurses to learn how to screen effectively. And she's done an amazing job with that. To how the images are then connected with the PAC system, and how easy it is to then review them afterwards. Like you said, you could be anywhere at your station and get the message. Um, for those people that aren't in the same position as you, what were the main challenges, do you think, at the beginning, and what does that mean in terms of your clinical practice now? I know you've touched on it, but what does that mean for the patients, in terms of having that seamless connection with taking the images to being able to read them?
Yeah, so I think that our intention was fairly humble at the beginning. It was, you know, um, let's just see if we can make this work with nurse delivered screening. So the
Mhm.
challenges, of course, was getting that started on the unit, because this was quite a departure from the traditional model all those years ago, where the ophthalmologist walks onto the unit with an indirect ophthalmoscope, and even when we got the cameras right at the start, many a few decades ago, that was always up to me to use, so that was a step change. And one of the things that sort of made me feel confident that it was doable was actually the Sundrop program in
Mhm.
the United States. I think they just published their first sort of tranche of results to show that it could be delivered by neonatal nurses. And I just had this conversation with Julie to say, well, what do you think? And you've met Julie. She's very passionate about ROP,
Yeah.
and she just jumped at the opportunity, really. So we started off on a relatively informal basis, but then um, that quickly evolved into a rapidly increasing interest from her fellow nurses. This was the thing that I was a bit surprised about, because when she started going around taking images, that sort of turned a few heads, and they thought, oh, well, that's a new thing. So what happened was that more nurses started to inquire gently with her about, oh, well, do you think I might be able to do that? And so, we kind of quickly got the message that this might be a sustainable project, because what we were demonstrating was that there was no more mystique about ROP.
Mhm.
People could see the retinas, people could see ROP, and nurses could actually demonstrate that to parents, and also have an increasing understanding themselves of what was going on um, with the baby. So that meant that the first challenge was, can we get a sustainable nurse-led or nurse-delivered service?
Mhm.
That was, I think, I was pleasantly surprised at how easy that was. And since then, we've had a stream of nurses who've come along, and we've had nurses obviously come and go and things like that, but we've always had people who are interested, and we've always been able to train people, and we're getting people from outside our organization who are interested in getting trained up. And Julie has, because she's gone through this process from scratch, she has developed an expertise on how to train people in ROP screening. So she's developed a bespoke training package. she won't mind me saying this, I don't think, but she is sort of obsessive compulsive about things in general. So
Mm.
when she developed this training package, it wasn't just all right, we'll just get the camera, put it on the baby's eye, and click away. It was everything from how to turn on the machine, how to prepare the baby, what safety parameters, how to set the baby up in the cot or in other venues, how to troubleshoot the machine, how to optimize your images, um, set other safety aspects, all those kind of things that she'd thought about very carefully and gone through, a very detailed process map of how you undertake ROP
Mhm.
screening and put it on paper, put down a whole competency package together, and then and for me to be able to supervise, not directly in the early stages, because I think it was felt that nursing, experienced nurses who screen can supervise new nurses. It's less intimidating. They feel they can have a conversation with them. They don't feel embarrassed or inhibited in any way. And then
Mhm.
only when they get to a particular stage of competency do I sort of start reviewing the images and giving feedback. And the feedback that I give, it's delivered in a way that doesn't discourage them. So if they're getting images which are suboptimal, I'll highlight the optimal bits. I'll
Mm.
say, you're doing this very well. Maybe you can, rotate the camera a little bit more, maybe enhance the lighting, maybe try and, eliminate that dark spot from the area of interest. So it's positive as much as possible, but
Mhm.
highlighting areas where they can improve. And the feedback I got from my feedback from the nurses is that they found that to be really helpful, and they have improved. So it's a process that doesn't take long, and I think particularly some of the very younger nurses pick this up really quickly.
Yeah.
I think if I was to start doing screening with a camera from scratch, having never had any experience of using it, I'd probably take a long time. But our our um, our nursing staff seem to be able to pick this up very quickly, take on board any areas for improvement, and really fly with this. So again, the challenge of finding the nurses, training the nurses, those have been overcome. And then the next challenge was really trying to make this into a seamless operation, where you have your RAP coordinator, you identify babies who require screening, identify the window by which they can be screened, um, they put in the requests for the images through our electronic patient record,
Mhm.
and that was a challenge because we have just switched to a full EPR. Everything has to be done through the EPR, and integrating that with the workflow for these babies. And so it took quite a lot of work between our IT department, our imaging department, who had overall charge of all the imaging devices we use in the hospital. This is not
Mhm.
just our neonatal retinal camera, but OCTs and slit lamp cameras, etc. Everything had to be run through this sort of department, um, and the retinal camera, the wide field retinal camera that we use, um, that had to be perfectly aligned with the intentions of the electronic, the way the electronic patient record works.
Mm.
So that was a challenge, but we managed to get that to integrate, and that meant that we could then order images and uh, send that message through to the Sectra Packs system, and then from there straight through to the machine,
Mhm.
uploaded onto the device. Um, you then upload the device with all the workflow for the day, and then you take the cart around, take your images, collect them all, and then at the end of the round, you plug it into a port, network port, and the images are then uploaded onto back onto packs, and then from packs it is then viewable through our EPR, which can then access directly the packs system.
Yeah.
So then we can see all that, and then we record everything electronically. So the ROP record, the iCrop chart, which we've designed so it fits in with the latest version of iCrop. That is now within the EPR, and we have therefore got everything working as it should do. So yeah, it's been a long process, but now that we've had it done, I think that it's working smoothly. So I think there are very few difficulties or hitches that we've encountered since we've managed to integrate the whole thing. So it works really well.
Yeah. So casting your mind back, pre-ICON, pre-retinal camera, pre-Julie, when you were doing indirect versus where we are right now at St Mary's, how has that impacted you and your workload?
So there are several strands to this. I mean, firstly, the first strand, I think the important strand actually, is the timeliness of screening. And we work on a level 3 unit, but our level 3 unit is a specialized level 3 unit. So we've got a lot of very sick neonates. We're a big regional center, so we have the sickest of the sick, and these babies are constantly having operations, investigations. They're in and out of the unit having various things done to them. So that means that if my day at work is a Thursday morning, so if I'm there on a Thursday morning and a particular baby scheduled for screening that week is about to have surgery, or they are having an MRI scan, then that baby's going to miss their screen. So what that means is that our neonatal nurses, they are there earlier in the week, Tuesday, Wednesday, and Thursday, and they can sort of anticipate this baby that's scheduled this week. They're about to have surgery scheduled on the Wednesday or the Thursday. They're not going to be able to have their screen on the Thursday. We'll take the opportunity now to screen them. So they'll take the camera and they'll do an opportunistic screen. Or if a baby is due to go home, and the unit is extremely busy, we're constantly on alert because the beds are fully occupied, and they need to move babies quickly. And if you can't keep a baby on the unit unnecessarily long. But on the other hand, they can't miss their screen. So again, it means that the team can take the camera and they can do an image, and then that baby has had their ROP screening. I can review it if needs be, so they can say to me, well, this baby needs to get off the unit. Can you please have a look? And I'll have a look and I'll say, yes, that's fine. Or I'll say, no, that one needs treatment actually. So that's the big advantage, I think. And then the other aspects of this is that there's teaching. So in the past, when I've gone around the unit with an indirect ophthalmoscope, what you'd have to do when you're teaching others to do ROP is that you'd have to just either let them have a go and see what they can see, and then you have a look, or you have a look first and then let them have a go and see if they can see it. But that means that the baby's having to be exposed to 2 lots of screening, which, it's quite stressful for the babies, and also stressful for the trainee and me, because I'm seeing that this baby's having a rather prolonged examination by a relatively inexperienced trainee. But when we've been able to take images, we in the morning, our routine on a Thursday morning, I go up with the team. We sit in the neonatal room office, and we review the images with them. They describe what they can see on the images, and we grade. And I'll either say, "Have you seen this bit or that bit? What do you think? Is this one for treatment, etc." That baby's only been exposed to one screen, but yet I've been able to teach 3 or 4 different clinicians, and in one sitting about ROP management. So it's been an immeasurable help in terms of treating, in terms of teaching. So that's something that we just couldn't have done before. And then the third aspect of this is the engagement of parents in the whole process, parents and nurses. And I've already touched on the fact that nurses have been really engaged with the concept of ROP screening using the camera system. But the other important thing is the parents as well. And when we've been able to use the cameras, what has happened, what I've noticed in the past is that before we had cameras, I'd go onto the unit with my indirect ophthalmoscope, indenter, speculum. That's the way I do it. I know people use this without speculums and indenters, but the whole process was something that actually many parents couldn't bear to watch, because it was, of course, quite uncomfortable for their babies, and they didn't see, maybe they didn't engage fully with the process, but they wouldn't, they would find somewhere else to go when I went to screen, and I'd have to talk to them later. Now what's happening is that the parents can actually see what's going on in their child's eye live, and so the seismic shift we've seen is that parents actually want to stay. They're fully engaged. They want to know about the ROP. They're having a look at the screen. They're asking questions. The nurses who are not involved in the ROP but who are looking after the baby are also asking questions and looking at the screen. It's just and the neonatologists who used to think this all a bit of a mystery are also engaged in the process. So everyone's engaged, and that's been a real benefit, I think, overall in terms of management of the patients, because when you've got engaged parents and nurses and doctors, management's better.
Yes, yeah, definitely, and I think that's a really important point. And I think I've been able to see that when I've been assisting screening, whether it's being delivered by nurses or by physicians, by clinicians, is that how often is it that the parents of the patient can see the inside of the child's eye, and so that engagement is really important, and I think that it's a pertinent point that you've raised there. Particularly, where I've noticed that is where there's follow-up needed, because you have that engagement earlier on, so that the understanding is much better from the parent's perspective, and therefore, when follow-up is needed, they're like you said, they're more invested in supporting that follow-up. 100%.
Yes, definitely.
Yeah.
Definitely. And then the other thing is if the baby needs treatment, it's not a surprise to them, and this is one of the things that used to be a little bit more of a problem in the past, is that parents, maybe they wouldn't come back. They wouldn't be able to get the message across. You wouldn't be able to get the message across that the baby is getting worse, and all of a sudden you're approaching the parents to say, oh, actually your baby, who's about to go home in many cases, needs treatment and needs to stay in. So with all this greater engagement, the upsettedness of parents hearing that their child all of a sudden they thought were getting better and was about to go home, needs treatment, that's no longer a surprise to them. And that also, I think, just prepares them psychologically for, these sort of, they are setbacks, but they're eminently treatable setbacks.
Yeah, agreed, agreed. So for those people that are kind of much earlier on in the journey than you guys are, whether they're thinking about having a nurse delivered program, or still using indirect, um, what are the words of wisdom or advice that you'd give them, bearing in mind that you've already gone through that?
Well, I think that you probably need a champion for this. I think that's probably the thing that's helped me along was the fact that we did have an RAP nurse who or just started off as an RAP coordinator. She was interested in eyes, but you know she didn't have much more of a role other than coordinating. But
Mhm.
she had we had a very good working relationship. She was a real advocate for the patients, for the babies and the families, and would always put me in my place if I was, not doing things right as far as she was concerned. So we had a good relationship, and we had one that I felt I could hand over more responsibility. So and she took that, and she became a champion for it. So what you
Mm.
need is you do need a champion uh, who is invested in developing themselves and then developing others. And that's I think that's probably the single most important thing. I mean, as an ophthalmologist, we're busy guys. We're busy people.
Yes.
We're busy in our clinics and what have you, and it's very difficult for us to invest the amount of time and energy to try and chivvy along others to take on the role.
Mhm.
But if you've got, I mean, I'm not saying neonatal nurses aren't busy, but they are on the unit all the time, and they're able to have those conversations, encourage others, demonstrate what they're doing, raise curiosity. All these things it will make the service sustainable. So sustainability is the one thing that people always ask me about, is saying, well, it's all very well you've got a nurse, but what happens when she goes or retires? And we do have a lot of nurses who come and go.
Mhm.
And so the important thing is to ensure you've got your champion, you've got someone who's stable in the unit, who is passionate enough about the service, and you can build that. You can build that passion by having those conversations with them, getting them more involved, um, getting them to do a little bit more than they possibly would have done in the past, but
Mhm.
within the confines of what's safe and that sort of thing. And then, pretty soon you'll find that you will raise interest. So I think that's the starting block. I think that's your starting point, and from there, you can build it up from there. I would, I mean, okay, the screening with a camera is a technical job,
Mhm.
um, but I would always probably advocate my top person to do that would be a neonatal nurse. If I had the
Yeah.
choice, if someone said to me, who should do it? Should it be the ophthalmologist? That would be bottom of my list. Should it be the neonatal nurse? Top of my list. Could it be someone else? Could it be an orthoptist? Yes, it could be. Could it be
Mhm.
someone else in the ophthalmic imager? Yes, it could be. But the reason why I think the neonatal nurse is best placed to do it is A, because they're on the unit all the time. B, they understand and know neonatal babies.
Yes.
And C, they are always able to advocate for the baby as well. Um, and I think this is these. It's not it has to be that or nothing else, but it ideally should be that.
Yeah. And that's really refreshing for me to hear, from a neonatal nurse's perspective, because that's my background too. but you're absolutely right. The neonatal patients, nurses, I beg your pardon, know their patients very well. They advocate for them. And so you're 100% right. I agree with you, although it's maybe slightly biased, but I think the neonatal nurses are definitely are well positioned
Mm.
to take on that additional responsibility for sure. Thank you. Well, I'm going to bring this to a close, Mr. Biswas. Thank you so much for your time. I really appreciate your insights, and it's really nice to hear, the amazing work that you guys are doing with your colleagues, the nurses, and the other clinicians at St. Mary's, looking after all of these babies and doing the best that you can for them. Thank you so much.
Thanks, Vic.